We're seeing a real evolution in how healthcare is delivered, right? And one of the most compelling shifts is, well, bringing hospital-level care right into the home.
Exactly.
Today, we're diving deep into a really fascinating angle of this. Direct admissions to hospital at home. So basically, completely bypassing the emergency department.
Yeah, exactly. And we've got a fantastic session to unpack today, actually. It features insights from healthcare leaders over in Singapore, NHS at Home, Sengkang General Hospital, KK Women's and Children's, and Woodlands Health.
Oh, wow. Quite a range.
Totally. And they're sharing, their real-world experiences and the actual data behind these quite innovative programs.
Okay, so to really get what's happening, it probably helps to have some context about Singapore's healthcare system.
Definitely.
It's compact, densely populated, facing the realities of an aging population. And they also like to say it's in a perpetual state of summer, which, well, you'd imagine has its own implications.
Right.
They operate with 3 key integrated healthcare clusters. And within this structure, hospital at home, or as they also call it, mobile inpatient care, MC at home, these programs are really taking hold.
And it's probably useful just to clarify some of the terms they use.
Good idea.
So hospital at home, that essentially means delivering acute inpatient level care right in someone's residence. It's basically substituting for a traditional hospital stay.
Okay.
Our focus today, though, is on direct admission. So going straight from the community, like a GP clinic or maybe a nursing home, into hospital at home without that ED visit.
Got it. Bypassing the ED.
Exactly. They also talked about early supported discharge, which is, moving patients from a hospital ward to home-based care sooner, and also admission avoidance, where conditions are managed in the ED well enough to prevent a full hospital admission altogether.
Okay, that makes sense. So our mission today is to really dig into the why and the how of these direct admissions to hospital at home in Singapore. Want to understand the benefits, the hurdles, and the different ways this model is being used for various patient groups.
Right.
Let's maybe start with the big picture. Direct admissions through Rachel's experience at NHS at Home.
Yeah, good place to start. So Rachel shared some initial data. This was from January to December of this year, and it's quite revealing. They saw 79 direct admissions.
Okay.
Now, that's about 4% of their total hospital at home admissions. But one of the first things that jumps out is the average age.
Oh.
Yeah, 78 years old for this group. That's notably higher than the average of 65 for their other patients.
Wow. Okay, so a key takeaway there seems to be that direct admission to home is, well, feasible for maybe a specific subset of older adults.
It seems so, yeah. A specific, perhaps frailer group.
That's a significant demographic difference. And what about the conditions they were admitted for? What were they seeing?
The top 3 were, well, pretty common things you'd see in hospital. Skin and soft tissue infections, urinary tract infections, and respiratory tract infections.
Right. And where were these referrals coming from? Who was sending them?
Their main sources were their primary care partners, so the polyclinics and the GP clinics.
Yeah.
They also got referrals from community teams like home nursing, hospice, community medical teams, also nursing homes, and their own virtual care center, which is sort of like a medical support hotline for their patients.
Ah, okay. So that really highlights a strong connection with community-based care providers then.
Absolutely. It's crucial.
So they're getting a good stream of potential patients, but I guess not everyone is a good fit, right? What were the main reasons they might have to decline a direct admission?
Yeah, their acceptance rate was around 60%, so there's definitely a careful screening process involved. So the main reasons for not accepting really underscored the importance of getting the patient selection right. Sometimes maybe the referring teams didn't have a full picture of what's suitable for hospital at home, or perhaps the patient's illness was just, well, too severe for home management.
Right.
Unstable vital signs, needing urgent tests you can only really do in a hospital. Those were also key factors.
That makes total sense. Patient safety has to be number one. What about practical challenges, like in the home environment itself?
Absolutely, that came up too. There are certain needs that are just hard to meet at home. Things like needing an immediate specialist review or specific medical gear like non-invasive ventilation, especially, outside of regular hours.
Right.
Or complex medication regimes like needing multiple IV electrolyte replacements or maybe managing potential reactions to new antibiotics. Those kinds of situations often still need that controlled hospital setting.
Understood. And what did they see in terms of like how long these direct admission patients stayed in the program and what their outcomes looked like.
Yeah. Okay, so their average length of stay was about 5.8 days. That was actually slightly shorter than their usual hospital admissions.
Oh, interesting.
Yeah. However, their rates of readmission within 30 days, return to hospital, and mortality did appear higher initially.
Okay.
But, and this is crucial, Rachel made a really important point. This direct admission group was generally more frail. The average age of those who were readmitted was 82.
82, wow.
Yeah. And in fact, about 60% of those who returned to the hospital were already getting care from home hospice or other community medical teams, suggesting, more of a palliative care trajectory anyway.
Oh, okay.
And the 3 deaths they recorded, those were for patients specifically admitted for end-of-life care at home.
Right.
So while the numbers might at first glance seem a bit concerning, the overall health status, the frailty of this particular group, is really important context.
So, okay, it sounds like while those stats might initially raise an eyebrow, the context of the patients, their age, their overall frailty is absolutely vital for understanding those results. It's not necessarily saying hospital at home isn't a good model for them.
Exactly. It's about understanding who this model is serving directly from the community. And Rachel mentioned they're working on increasing direct admissions, and, they'll share more data as the program grows.
Good. Okay, now let's maybe turn our attention to a really interesting area you mentioned. Direct admission specifically from nursing homes. Dr. Leanne from Senkang General Hospital talked about this.
Yes, and the Senkang experience really suggests that building a solid foundation of virtual care and strong relationships with those long-term care facilities is pretty critical before you can successfully implement direct hospital at home admissions from those settings.
Okay, tell us about Senkang. They serve a specific area.
Yeah, Northeast Singapore. It's densely populated. And what's really notable is the sheer number of nursing home residents in their patch. Something like 20% of all nursing home residents in Singapore are within their service area.
20%, that's huge.
It's a significant concentration, yeah. And they've actually been running a virtual care consultation team for nursing homes. It's called Eagle Care Act since 2020.
Eagle Care Act, okay.
Yeah, this grew out of their community outreach work, and now it covers 10 out of the 13 nursing homes in their region.
So this Eagle Care program, it's basically like a remote consultation service. How does that work?
Precisely. It's a 247 virtual consult service. It's designed to address common acute conditions you see in nursing homes: pneumonia, UTIs, cellulitis, even things like constipation or minor head injuries.
Right.
They also provide support for palliative care and managing complex wounds. And importantly, the nurses in the nursing homes are trained up on using standardized tools like the NUWS protocol. That's a way to track vitals and spot deterioration. And SPR, a structured way to communicate the patient's status to the virtual consult team.
That sounds like a fantastic way to get timely medical support without always having to, transfer residents back and forth to the hospital. So the virtual team can assess and recommend treatment remotely.
Yes, they can. But Leanne was clear this isn't the same as full hospital-at-home care. It's more of an on-demand consultation service.
Gotcha.
But what's really interesting is how this initial virtual care program kind of paved the way for other support services for the nursing homes. Things like specialized wound care teams, help managing medical lines and tubes, partnerships with specialist nurses from the hospital, and a big focus on advanced care planning. They even have a dedicated funded program for ACP with a doctor, nurse, and an ACP coordinator.
Wow, that proactive approach to advanced care planning seems particularly valuable in that nursing home setting.
Totally. It helps ensure care aligns with residents' wishes.
So where do direct admissions to hospital at home fit into this existing, quite sophisticated framework?
Well, this is where it gets really exciting, but also a bit frustrating for them, I think. Currently, they actually aren't able to directly admit patients from the Eagle Care program into their hospital-at-home program.
Oh, really? Why not?
It's still under regulatory review.
Ah, okay. Bureaucracy.
Seems like it. But the groundwork they've laid over the last 4 or 5 years with the virtual consult service, building up expertise in the nursing homes, it puts them in a really strong position for when they get the green light.
Right. They've built a foundation. So what kinds of conditions would they see as suitable for their hospital-at-home program coming from these nursing homes? Would it be similar stuff or maybe more acute?
Leanne suggested it could actually include cases with potentially higher acuity. So patients may be needing IV drugs or daily in-person doctor visits, things that go beyond what the nursing home can typically provide.
Okay. And even though direct admissions aren't happening yet, that Eagle Care program itself has already had a pretty substantial impact, hasn't it?
Oh, absolutely. Leanne reported 700 consultations through Eagle Care just in the past year. And that resulted in a 62% avoidance rate for ED visits.
62%. That's a huge reduction in transfers.
Massive. But she also noted that around 40% of patients still ended up going to the hospital. Why? Because that direct pathway to hospital at home wasn't available. So it really highlights the gap they're trying to fill.
Yeah, you can see the potential right there. They even did a pilot program with one specific nursing home, Grace Lodge, right? What did that show?
Yes, and the data was pretty stark. Out of 160 ED referrals from Grace Lodge, almost all of them resulted in a hospital admission.
Wow.
Only 18 of those patients were admitted to the hospital at home program. Again, it just emphasizes the need for that streamlined direct admission process and also the importance of having those advanced care plans sorted out beforehand.
Definitely. So what are the key advantages Leanne sees for enabling these direct admissions from nursing homes?
Well, the advantages are significant.
Yeah.
Reducing those hospital transfers is a big one, obviously. That leads to better continuity of care and care that's more likely to be aligned with the resident's ACP.
Makes sense.
It allows for more proactive, timely interventions. It completely bypasses those often long waits in the ED. And it's a much more efficient use of resources. Nursing home staff don't have to spend hours transporting residents.
Their point.
Ultimately, it just lessens the strain on the ED and helps avoid potentially unnecessary hospital admissions.
It really sounds like a promising step forward once they get past that regulatory hurdle. Okay, let's switch gears completely now and talk about a very different group, newborns with jaundice. Dr. Kelly from KK Women's and Children's Hospital shared their experience.
Yeah, quite a shift. KK Women's and Children's is the largest specialized hospital for women and children in Singapore, so they handle a huge volume of births and related conditions. And Kelly shared this really touching story, actually, about a 3-day-old baby with high bilirubin levels. They were able to admit the baby directly home for phototherapy treatment.
Directly home. Wow.
Yeah, avoiding that separation from the breastfeeding mother, which is, so important in those early days.
Absolutely.
Yeah.
That really paints a picture, a tiny baby getting treatment in their own home instead of a hospital ward. They even have a newsletter highlighting how well their home phototherapy program works.
They do. They emphasize the convenience, effectiveness, and safety. And they recruit patients from various places within the hospital, the children's ED, inpatient wards, specialist clinics, but crucially also direct referrals from polyclinics.
Those government primary care clinics again.
Exactly. Those direct links seem really important. And Gelly clarified their hospital at home program actually covers PEDS, dermatology, and O&G, but yeah, her talk focused on neonatal jaundice.
Now, okay, the idea of sending a newborn home directly from a primary care clinic with jaundice, that might understandably make some people a bit nervous about safety. What safeguards do they have?
Yeah, safety is absolutely paramount, as you'd expect. They have a very careful selection process. They focus on infants who are older than 72 hours and who only need single blue light phototherapy.
Okay, specific criteria.
Very specific, and thorough risk assessment is critical. Kelly mentioned Singapore actually has standardized guidelines for phototherapy thresholds across all pediatric hospitals, which helps.
That standardization helps.
Definitely. They also make sure the home environment is suitable for the equipment and that the parents are willing and, importantly, able to participate actively. That means monitoring the baby's temperature, doing daily virtual check-ins,
Right.
And they have a 24-hour support hotline available, too.
So it's a very specific group, and the parents get significant support. What's the actual process, then, for a direct admission like that, say, from a polyclinic?
It involves quite a bit of coordination. So at the polyclinic, the caregivers get detailed counseling about the program, including the financial side, usually via a Zoom meeting with the hospital's admissions team.
Okay.
Then the hospital at home team, which includes advanced nurse practitioners, ANPs, does a teleconsultation to get their agreement and formal consent.
Right.
Then the baby goes home. A vendor delivers the phototherapy unit within about 4 hours. And then, crucially, an ANP makes a home visit.
An in-person visit.
Yes, to do a physical exam of the baby and get that formal consent signed in person. That personal home visit seems really key for that initial assessment and building trust.
Yeah, I can see that. What kind of numbers are they seeing with this program? How established is it?
It's approaching its second anniversary, actually, in April. They've already enrolled over 300 pediatric patients in total.
Wow.
Of those, 192 were newborns with jaundice getting phototherapy at home. And impressively, about 20% of those jaundice cases were direct admissions from primary care.
20% direct from primary care. That's a significant number of babies avoiding a hospital stay altogether.
What about readmissions? That's always a key measure.
Good question. The readmission rate was around 8%, and Kelly broke these down into clinical reasons like fever or poor feeding and non-clinical reasons.
Such as?
Things like maybe the parents felt overwhelmed with managing the home phototherapy, or there were difficulties with compliance.
Okay.
They also have a really well-defined U-turn process for those readmissions, with different levels of urgency depending on how the baby's doing, ranging from a direct transfer to the wards up to an emergency transfer if the baby is really unwell. It sounds like they've really thought through the what-ifs.
Yeah, seems very thorough. What were some of the other sort of hurdles they mentioned in setting up and running this?
The main challenges they flagged were refining their clinical criteria, always making sure there's selecting the right babies, not missing infants who really do need inpatient care. Also, the logistical complexities, coordinating everything.
Right. And staffing, particularly having enough skilled A&Ps to do those home assessments. But despite those challenges, Kelly really emphasized the overwhelmingly positive feedback from parents.
I bet.
Yeah, and their belief that this program is fundamentally changing how they deliver compassionate, safe, and family-centered care for these newborns.
It's a truly innovative approach, especially, for such a vulnerable group. Okay, let's move on to our final presentation from Dr. Pauline at Woodlands Health. She discussed direct admissions from their transitional care program. This sounds like a very smart way to sort of integrate different levels of care.
It really does. So Pauline explained their transitional care program, or TCP, is specifically designed to kind of bridge that gap between a hospital stay and going home for complex patients. Patients who are maybe waiting for ongoing primary care to kick in.
Okay.
It's a community-based program, but run within the hospital system. Involves a multidisciplinary team, links with community services. It typically lasts for a few months.
A few months, okay.
Yeah, and it includes home visits by nurses trained in community care, plus input from doctors and therapists as needed before the patient gets fully handed back to their primary care doc.
So it's like a step-down service after hospital, making sure that return to the community is smoother. How does direct admission to hospital at home fit into this model then?
Well, this is what's really clever. The doctors and nurses who work in the transitional care program, they're also trained in providing hospital-at-home care.
Ah, cross-trained.
Exactly. Which means if a patient who's already in the TCP develops a new acute problem, the TCP team can assess right there if they're suitable for direct admission to hospital at home without automatically sending them back to the ED.
Okay, that's efficient.
Totally. They can evaluate the patient's stability, check the home setup, counsel the patient and caregivers, do an exam, maybe even some initial tests right there in the home.
Right.
Then they discuss it with the hospital-at-home physicians, and if it's all good, the patient can be enrolled the same day. If not, or if they get worse, then yes, they'd go to the hospital. But that seamless potential transition is key.
That sounds incredibly efficient, and much more patient-friendly than bouncing back to the ED. What does the actual hospital-at-home process look like for these direct admissions from TCP?
Pauline described a very streamlined flow. It includes that initial home visit and assessment by a doctor, sorting out medications, developing a care plan. Nurses do crucial teaching with the patient and caregivers how to monitor vitals, when and how to call for help.
Okay.
A coordinator handles the sort of finance and admin side of enrollment. And because this group often includes frail, maybe even end-of-life patients, there's a really low threshold for doing physical assessments and proactively discussing goals of care.
Good.
And then, when the acute issue settles, they're promptly handed back over to the TCP team again. No ED visit needed for that discharge back to transitional care.
Nice closed loop. They ran a pilot project on this too, right?
Right.
What did the data show there?
They did, yeah. Ran for 6 months, involved about 7% of their TCP patient population. The average age here was quite high again, 84. Mostly older women, moderate frailty.
Oh.
Their average length of stay in the hospital at home part was a bit longer, around 9 days. Common underlying health issues were things like dementia, end-stage kidney disease, but not needing dialysis and heart disease.
And the conditions they were actually admitted for, from TCP to HaH.
Common ones were things like cellulitis, postural hypotension, dizziness on standing fluid overload, low sodium levels, things you might expect in that population.
Right. And the outcomes for these patients, did they mostly manage okay at home and go back to TCP?
Yes, the vast majority were successfully discharged right back to the transitional care program. Only 2 patients needed to return to the hospital.
Oh, what happened there?
One had chest pain, but it turned out to be unrelated to their original issue, and the other was admitted directly to a palliative care ward due to increasing needs from their underlying illness. So generally very positive outcomes from the pilot.
Pauline had some really insightful reflections on this pilot, didn't she? What were her main takeaways?
Yeah, she really highlighted the positive impact on providing care that's truly patient-centered, how effectively it bridges that hospital-home gap, and the critical importance of strong collaboration across different disciplines.
That collaboration piece keeps coming up.
Absolutely. And the ability for patients to potentially move between hospital at home and transitional care without a full hospital admission, that creates a really integrated care pathway.
What about the challenges they face setting this up?
Well, similar themes, again, really. Carefully selecting the right patients, getting the screening and criteria right.
Yeah.
That was a challenge.
Yeah.
Ensuring seamless communication and collaboration between the HaH and TCP teams was also crucial. And they also mentioned, regulatory and funding aspects always need ongoing consideration.
Right. And looking ahead, Woodlands Health is expanding the role of nurses, even letting them identify potential HaH candidates directly from the ED or inpatient wards.
Exactly. They've started with nurses screening for common things like cellulitis, and they have plans for a phased rollout to include other conditions like rhabdomyolysis, diabetes issues, uncontrolled hypertension, UTIs, gastroenteritis.
A phased approach makes sense.
Yeah. Their thinking is this empowers nurses, lets them use their skills, frees up doctors for the more complex cases, and just improves overall efficiency.
Yeah, you can see the logic. It sounds like this integrated approach has potential for some really significant benefits. Pauline also touched on the sort of overall advantages of direct admission to hospital at home more generally, didn't she?
Yes, she did. She emphasized the value of getting acute care in your own familiar surroundings, less stress, potentially better recovery. She also highlighted how it can empower the healthcare teams, giving them more autonomy in assessment and treatment decisions, and how it can contribute to the long-term sustainability of managing chronic diseases.
It's really fascinating to see these diverse strategies for direct admissions playing out across different patient groups in Singapore. The session then moved into a panel discussion, right? I bet that brought up some valuable points.
It certainly did. Sheila O'Riordan from England chimed in, mentioning their experience with large-scale hospital-at-home programs, really emphasizing the benefits they see for frail individuals and, again, that critical role of advanced care planning.
Right, ACP again?
Yeah, and she raised an interesting question about the potential for direct referrals from ambulance services.
Ooh, that's interesting. Like paramedics identifying suitable patients at the scene. What was the response?
Leanne from Sengkang explained that, many of their nursing home partners use private ambulance services, and they do collaborate with them. But integrating with the main public ambulance system, that brings challenges. Things like aligning training protocols, building those strong working relationships with paramedics. It takes time, but it's definitely something they're considering for the future.
Makes sense. Then Kendall Hall from Canada asked that really important question. How do you demonstrate value for money to the funders beyond just, the obvious patient benefits? How do you make the economic case?
Yeah, the million-dollar question, right? The response really highlighted that value isn't just about cost savings. For patients, yes, there's the improved experience, the familiar environment, huge for people with dementia, for example.
It's true.
But for the healthcare system, they're seeing reduced ED admissions, fewer overall hospital admissions, lower rates of nasty things like hospital-acquired infections and delirium, shorter lengths of stay when hospitalization is needed, and crucially freeing up those valuable hospital beds. They also mentioned there's actually an ongoing national audit in Singapore specifically looking at evaluating the value of these programs. Okay, so they're actively trying to quantify it. Jen Klein from the U.S. asked about that transition between transitional care and hospital at home specifically. How long patients typically stay in transitional care in Singapore?
Right. Pauline clarified that TCP in Singapore can last anywhere from a few weeks up to around 3 months. It depends on the patient's needs. The main goal is reducing those recurrent hospital admissions.
Okay.
And she estimated that maybe 20 to 30% of these TCP patients might still have acute episodes where hospital at home could offer a viable alternative to readmission.
Got it. There was also a practical question about the neonatal jaundice program, how they actually do the blood tests.
Yes, the serum bilirubin testing. Kelly explained they follow the same protocol as they would inpatient. Daily heel prick blood tests done by trained third-party providers right in the patient's home.
The samples then get transported to the hospital lab, which, in compact Singapore is relatively quick, maybe 1-2 hours transport. Results are usually back within 2-3 hours total. And they also use those point-of-care skin measurements, transcutaneous bilirubin, as an extra monitoring tool.
Okay, sounds efficient. And Julietta from Canada asked Leanne about overcoming barriers, specifically working with the long-term care facilities.
Yeah.
How do they build those bridges?
Yeah, that was a great question. Leanne really emphasized building strong relationships. It was about mutual respect, understanding the needs of the nursing homes. Singkang proactively engaged with them right from when the hospital opened in 2020.
So, early engagement.
Very early. Building rapport with the nurse managers, the care teams. Doing it with humility, she said. Developing protocols based on what the nursing homes needed. And carefully selecting partners who really shared their commitment to patient care and safety.
That collaborative, ground-up approach sound absolutely essential. Was there also a clarification about who does what? Like the division of responsibilities between the nursing home staff and the hospital home team?
Yes, exactly. The key point was, once a resident is enrolled in the hospital at home program, the HaH team takes full responsibility for managing the acute medical issue. That includes things like IVs, doctor visits. Meanwhile, the nursing home staff continue doing what they normally do, help with daily activities, give oral medications. That clear line seems really important for it to work smoothly.
Definitely avoids confusion. Katie Swans from Australia mentioned their program where ambulance crews refer falls patients directly to an early clinic appointment, bypassing the ED. Is anything like that happening in Singapore?
It's slightly different. The very short ambulance travel times in dense Singapore maybe make that exact model less directly applicable.
Yeah.
But there is a growing trend towards setting up urgent care clinics for less severe cases. And also, Pauline mentioned their transitional care program can enroll patients prone to falls into hospital at home for closer monitoring and support, which is another way to manage that risk outside the ED.
Okay. And Emily from the U.S. asked how patients actually get into the transitional care program in the first place.
Pauline explained it's usually physician-directed. Doctors identify patients based on specific risk factors, suggesting they'd benefit from that extra monitoring post-discharge. But enrollment always involves a thorough discussion with the patient and their family first.
Makes sense. Shared decision-making. Finally, there was a question from the online portal about regulations and payment structures for direct admission and how they ensure it's appropriate. Like, who's the gatekeeper?
Yeah, good practical question. The response highlighted their virtual care center hotline again. It acts as a central triage point. Primary care docs can call, discuss cases, and a team care managers, nurses, a physician assesses if hospital at home is right, or if the patient really needs the ED or maybe just outpatient care.
So a clinical filter.
Exactly. And for the neonatal jaundice program, Kelly specifically mentioned their proactive efforts to educate and build confidence among the primary care providers, using secure messaging, brochures, videos, case discussions, so they feel comfortable making those direct referrals.
It's really clear from all these insights, isn't it? Direct admissions to hospital at home aren't just some future idea in Singapore. They're happening now, they're evolving, and they're offering real potential benefits across a huge spectrum of patients, from newborns right up to the very elderly in nursing homes and those navigating that tricky transition home.
Absolutely. We've seen some really innovative approaches being tested and implemented, leveraging virtual care in nursing homes as that stepping stone.
Yeah.
That highly specialized, successful program for direct admissions for neonatal jaundice straight from primary care, and the really thoughtful integration of hospital at home with existing transitional care services.
And the themes that just kept popping up across all the talks and the discussion were that strong commitment to patient-centeredness and safety, the absolute necessity of effective collaboration across different bits of the healthcare system.
Crucial.
And that ongoing dedication to actually demonstrating the value and working through all the logistical and regulatory stuff that inevitably comes with these kinds of groundbreaking models.
Yeah, it really prompts you to think, doesn't it? As healthcare systems everywhere face pretty similar challenges, aging populations, stretched resources, could these experiences and insights from Singapore offer, well, a valuable glimpse into the future of how we might deliver acute care?
A future where maybe the specialized expertise and resources of the hospital can actually be brought directly to the people who need them most, wherever they happen to be.
Exactly. It certainly gives you, the listener, a lot to think about. Maybe it's time to consider how these models could potentially be adapted or implemented in our own communities, and perhaps delve deeper into the ongoing research and discussions in this really important, really dynamic area of healthcare.